So after having understood the basic glomerular structure, we are moving ahead. And now what are we going to do? We are going to discuss about the clinical presentations of glomerular disorders. We are going to discuss on the clinical presentations of glomerular disorders. So let me begin by telling you what am I going to discuss in this particular module. Okay, that is clinical presentations of glomerular disorders mean how do these disorders clinically present to a nephrologist or a physician. Okay, because see, glomerular disorders are many. You have a big umbrella of disorders in this group of glomerular disorders. And mind you, the presentation of these disorders can be varied. It is not like all glomerular disorders present with same clinical features. You will have variations. So, in this module, I am trying to tell you in what all ways can a glomerular disorder clinically present to you. So that once you are thorough with the various clinical presentations, it is easier to categorize individual disorders, which would make learning more easy, and also in your clinical practice also to understand, okay, this particular presentation is likely to be seen in this particular disorder. So it is easy to learn that way. Okay, so let's begin with the clinical presentations of glomerular disorders. Okay, so I'll just begin by showing you a picture, an image, something that we have discussed in the previous module. But just to tell you on the various mechanisms of glomerular damage, so that the individual disorders, naturally when you have a disorder, glomerular disorder, there has got to be a damage to some of the components, and depending upon what component is affected or maybe predominantly affected, the manifestations can vary. So just a recap of what we have learned. Now just tell me, I'm sure that you are now in a better position than me to explain this picture, simple one. Are you able to see the capillary endothelium here? Yes, you have the glomerular capillary endothelium, and the same capillary, you can see the capillary lumen, and we have already learned that the capillary endothelium will have certain fenestrations, okay, 50 to 100 nanometer fenestrations in the capillary endothelium. And then I am sure that you are able to appreciate the glomerular basement membrane. Yes, glomerular basement membrane. And also just adjacent to the glomerular basement membrane, are you able to see the visceral epithelium of the Bowman's capsule and subsequent interdigitating foot processes, okay, which are closely adjacent to the glomerular basement membrane? You are able to see that, yes. And also you are able to see the mesangial cell as well as the mesangial matrix. Yes, you are able to see them. And also you are able to see the parietal epithelium of the Bowman's capsule. Yes. And this one is the urinary space. So between the capillaries, that is the capillary lumen and the urinary space, you have the filtration slit, correct? You have the filtration diaphragm, you can call it, okay, filtration diaphragm, which is again responsible for filtering, across the barrier that separates the capillary lumen and the urinary space, which is again very important. So why am I telling you again? This is just because of the simple fact, once you learn, okay, what are the components that can be damaged, the clinical presentations are going to be very easy for you. Okay, all right. So you have understood this picture. Just one more picture to show you this is the electron microscopic view of the glomerular filtration barrier. Okay, the filtration barrier. So what are the components of the filtration barrier? It is very clear for you. Tell me, what is this particular layer? This particular layer that you are seeing is the capillary endothelium. The capillary endothelium. Yes. And what is the layer just adjacent to that? Tell me. It is the glomerular basement membrane. And are you able to see all these foot processes? Yes, they are the foot processes of the podocytes. Foot processes of podocytes. Okay, very clear. Okay. And this is the luminal side, and this will be the urinary space. Okay. And filtration has to occur, okay, from this capillary lumen across the barrier, and it goes to the other side. And just one more point I want to tell you about the glomerular basement membrane. If you carefully observe the glomerular basement membrane, you will understand that this is a trilaminar structure. Okay, trilaminar structure. Obviously, you won't be able to appreciate the finer details in a light microscope, but in an electron microscope as shown in your image, you can see the trilaminar structure. So when I say trilaminar structure means it is consisting of three components. So let's try to see what are the individual components of the basement membrane. See, it has got a central part which is quite dense, and you can call it the lamina densa. Okay, lamina densa. And then it has got an interior part and an exterior part which is not that compactly arranged. So the one that is outside is known as lamina rara externa, lamina rara externa, and the interior one is the lamina rara interna. Okay, lamina rara externa, lamina rara interna. Okay, so these are the components of the basement membrane. Okay, you have got to be clear with that. All right. Okay, now when you say about the glomerular, the mechanisms of glomerular damage, see, predominantly you can have an antibody mediated, because it is quite obvious that when you have a glomerular damage, it is likely to be due to the immune mechanism. And in the immune mechanism, it can be antibody mediated attack to the glomerulus, whatever component it may be. It could be again the antibodies forming immune complexes, which is again the most important one, immune complexes. And sometimes because the immune complexes are formed, there may be a complement activation as well. There may be complement activation as well. Okay. So, is there any role for the other cells like T cells? Yes, T cells may also have a role. You may have role for the NK cells, okay, the natural killer cells. Okay. So, these are the predominant mechanisms by which you will have a immune mediated attack to the components of the glomerulus. Yes, the other components like your platelets, your macrophages, they also would contribute to this immune mediated attack. Okay. Alright, so this is how the damage can occur. Now I am going to show you a very simple diagram from Robbins, a simple one. Okay. So what am I trying to tell you? Are you able to see certain numbers 1, 2, 3, 4? Okay. So what am I trying to tell you? I am trying to tell you that, see, when you have antibodies and immune complex formation, these immune complexes can be deposited at various sites, and I told you depending upon what site is involved or predominantly involved, the manifestations can vary. Okay, because you have a whole list of glomerular disorders, and where does the immune complex deposition happen differs in various disorders. Now, I want you to focus on one at a time. See, what is shown here is just the glomerular basement membrane and the components. Okay, so that is a lamina densa, lamina rara externa, lamina rara interna, the endothelial layer as well as your epithelial layer formed by the food processes of the astrocytes. So, just they are showing a structure of the filtration barrier, but our interest is the other picture, where we are trying to see where all these immune complexes are getting deposited. See, just notice the figure 1. Okay, not the figure 1, the one which is labeled as 1. So there, whatever is shown as black, okay, whatever is shown as black in this particular image are the immune complex deposits. So you tell me the one marked as 1, the immune complex deposits occur where? Is it in the endothelium, subendothelium, or is it in the basement membrane or the subepithelium? See, clearly you can see that these are the food processes of the podocytes, and that is your visceral epithelium, and you have the immune complexes just beneath the epithelium. So what will you call it? You will call it subepithelial immune complex deposits. Okay, you will call it subepithelial immune complex deposits. Okay, just adjacent to your visceral epithelium, adjacent to your food process of the astrocytes, that is food processes of the podocytes, that is where you have the subepithelial deposits. Second, number 2. So number 2 means you are able to see the immune complex deposits are mainly in the glomerular basement membrane. You agree with me or not? So can you say that these are predominantly membranous immune complex deposits? Membranous immune complex deposits. Okay, membranous immune complex deposits. And what about number 3? Number 3. See, number 3 is the immune complex just adjacent to your endothelium, capillary endothelium. So that is a subendothelial immune complex deposits. Subendothelial immune complex deposits. Okay, so that is also very clear. And what about number 4 that you are seeing in the picture? Number 4 that you are seeing around here. So all these immune complexes are depositing in the mesangium. So these are mesangial immune complex deposits. Mesangial immune complex deposits. So see, after this module, when we learn regarding the individual glomerular disorders, I will be telling you that okay, in this particular disorder you have say subepithelial immune complex deposits, okay, producing certain humps, okay, which we will learn later, okay, subepithelial humps. So okay, what disorder is this? Okay, like that we will discuss individual disorders. We will again understand, okay, in this particular disorder, immune complex deposition is occurring here, something is membranous immune complex deposits, something is mesangial, in some cases both sides. But these are the sites where the immune complexes can get deposited. And remember, I told you something, depending upon where predominantly the attack is. Okay, because in many glomerular disorders, you can have overlap. It is not that in one particular disorder only the mesangium will be affected. You can have an affection of your mesangium and maybe your epithelial region as well. So you will have that mix and match combinations, but this is the overall outline that you have got to know. Very clear? Okay. Now, after having understood that, let's try to move to the clinical presentations per se. That is our actual topic. So, clinical presentations of glomerular disorders. See, clinical presentations of glomerular disorders, there are 6 patterns, okay, or 6 presentations for the various glomerular disorders, okay. So we are going to see what are the 6 patterns or presentations of glomerular disorders, okay, in what all ways can they present. So number 1, they may be totally asymptomatic, okay, totally asymptomatic and probably incidentally detected. We will come to individual the presentations later, but first let us list down what are the clinical presentations. So after asymptomatic, next presentation is that of a macroscopic hematuria. Okay, macroscopic hematuria. It is the second presentation. The third clinical presentation is nephrotic syndrome. Nephrotic syndrome. The fourth one is nephritic syndrome. Nephritic syndrome. The fifth one is rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis, which you can abbreviate as RPGN. And the sixth presentation is with a chronic glomerulonephritis. Chronic glomerulonephritis. So these are the 6 patterns of or presentations of glomerular disorders. Okay. So now let's see individually on the patterns of presentations. So just the important points. First of all, the first presentation I told you is asymptomatic. Okay. So what do I mean by asymptomatic? See, asymptomatic presentation means the patient did not have any clinical symptoms per se, and probably when he underwent, say, some urine examination for maybe like when you go to say a job recruitment, sometimes they might ask you to do the various blood tests and urine examinations. So probably the patient, the person, when he was subjected to a urine examination, there might be a bit of a microscopic hematuria, okay, microscopic hematuria, or sometimes you might have a proteinuria, okay, proteinuria. And since this patient is asymptomatic, most likely it is a non-nephrotic range proteinuria. It is less likely that a patient with a totally nephrotic range proteinuria is asymptomatic. So you might have proteinuria in the non-nephrotic range. So microscopic hematuria means you may have more than or equal to 3 RBCs per high-power field, okay, in a spun urinary sediment, okay, a spun urinary sediment. So when I say spun urinary sediment, it means it is spun at 3000 RPM for 5 minutes, 3000 RPM for 5 minutes. So, and you find more than or equal to 3 RBCs per high power field, you say that there is a microscopic hematuria. So, see this particular group of individuals, asymptomatic group. So, suppose you have a patient who is incidentally detected to have a hematuria or a proteinuria or a combination. Okay, so in this group, either the patient may have a microscopic hematuria or a proteinuria or sometimes both. Now remember that though the patient is not having any symptoms, this is not a group that you can take lightly, okay, because he is having some problem, and yes, he has not manifested the disease as of now, but in due course he is likely to manifest. So in this case, you have got to work up the patient, okay, you have got to work up the patient. Yes, you will have to go for a renal biopsy also in this particular patient, okay, because see, they may not be willing first of all for the renal biopsy. Okay, just think, somebody is totally asymptomatic and you check the urine and you find that there are a few RBC cast, or maybe some proteinuria is there. But it is important that you have a talk with the patient and tell him that, see, in this particular examination, there is a slight abnormality, and it would be good that we proceed ahead with the investigations and find out why you are having this problem. Okay, always remember, when you have a asymptomatic presentation, especially microscopic hematuria, so there is a chance that in females, especially during the menstrual cycles, there may be a contamination. So do not mistake that for a microscopic hematuria. Okay, that is one thing that you have got to keep in mind. But in general, let me tell you one point. See, some patients in the early stages of glomerular disease may not have symptoms. All what they might have will be a urine examination showing some findings. In that case, you have to evaluate the patient further to see what is the problem, so that whether you can intervene early or not, that is a question here. Okay, that is the asymptomatic presentation. Often, I told you, for job recruitments and all, sometimes they may ask for the investigations. Similarly, when studies are conducted in a community also, okay, you are doing a mass study in a community also, you might be able to pick up such individuals who are having asymptomatic hematuria or asymptomatic proteinuria, okay, or sometimes both in combination. Okay, so this is not a group that you can neglect. This is a group that has to be evaluated. Okay, that is the asymptomatic group. I hope it is clear. And you can just see, yeah, this is the a urine sediment of a patient who was totally asymptomatic. He had RBC cast. Okay, he had RBC cast. So will you evaluate this patient? Yes, he has to be further evaluated. Okay, so that is the first presentation, asymptomatic. Okay, all right. Second, you can have a macroscopic hematuria. Okay, you can have a macroscopic hematuria. Macroscopic hematuria. That is, it is not a microscopic hematuria. The patient might be having a frank hematuria. So there are certain glomerular disorders like an IgA nephropathy where you can have hematuria as the presenting feature. Okay. So remember that in such individuals you have to evaluate. So remember, when I say macroscopic hematuria as a presentation of glomerular disorder, it doesn't mean that anybody and everybody with a macroscopic hematuria has a glomerular problem. You know that most often a patient with a macroscopic hematuria is likely to have a urologic problem. Okay, he might be having some renal calculi and there might be a hematuria. So always try to evaluate and find out. You have got to rule out the urologic causes, okay, and then think of the other glomerular causes and all. So macroscopic hematuria may be a presentation of a glomerular disorder. So after macroscopic hematuria, the third presentation, very, very important, you have got to know this in detail, is regarding nephrotic syndrome presentation. A presentation with a nephrotic syndrome. Remember, when we learned regarding the glomerular disorders, it is not like, remember that nephrotic syndrome is not a single disease. It is actually a clinical presentation, and there are various disorders, either a primary glomerular disorder or maybe some secondary disorder that can present with a nephrotic picture. Okay, so have in mind that this is a syndrome, nephrotic syndrome. So whenever you have a syndrome, you will be having certain components in the syndrome. So what are the components of a nephrotic syndrome? That is what we are going to learn. So when you have a nephrotic syndrome, one most important feature is that you will have proteinuria. Okay, I am going to teach you the 5 components of nephrotic syndrome, and to say that somebody has a nephrotic syndrome, all these 5 components should be present. So one is going to be proteinuria. Second is hypoalbuminemia. The third is going to be edema. Okay. The fourth one is going to be hypercholesterolemia. Okay, hypercholesterolemia. And the fifth one is going to be lipiduria. Okay, lipiduria. So these are the 5 components, all of which has to be present to label somebody as a nephrotic syndrome. Okay, to label somebody as a nephrotic syndrome. So why not discuss the individual components of nephrotic syndrome? First of all, to begin with, proteinuria. Okay, proteinuria. First of all, let me tell you that patients with nephrotic syndrome have a nephrotic range proteinuria. You call it nephrotic range proteinuria. So nephrotic range proteinuria is means a significant proteinuria, very significant proteinuria is there, and quantitatively we say that more than 3.5 gram of protein per 24 hours, okay, that is per day. If you have a proteinuria more than 3.5 gram per day, that is when you say there is a nephrotic range proteinuria, okay. Now please remember that when I say more than 3.5 gram per day, so this particular entity, high degree of proteinuria that you see in case of nephrotic syndrome, is again very important and is responsible for many of the clinical manifestations of nephrotic syndrome, okay. And how do you test or how do you say that a patient has nephrotic range proteinuria? See, there are a couple of ways. One is you can go for a 24-hour urinary sample collection, 24-hour urinary sample collection, and when you have a total protein loss, okay, the protein loss more than 3.5 gram per day, protein loss more than 3.5 gram per day, or you can say probably a albumin, okay, because in your proteinuria, albumin is one of the components. So if there is an albumin loss more than 2.2 gram per day, in both these scenarios you can say that this is a nephrotic range proteinuria. So not just a protein loss more than 3.5, even your albumin loss more than 2.2 gram per day, you can also call it a nephrotic range proteinuria. So I told you, you can go for a 24-hour urinary sample collection. But see, a 24-hour urinary sample collection where a patient is being given probably a can, okay, and he is being asked to urinate in that particular can for a whole day. So, but this method of collection over a 24 hours, you know, it is cumbersome, okay. Nobody would like to have urine collected in a whole day in a container, okay. Sometimes he might actually forget about the container, and maybe, you know, there is a chance that he might go to the toilet in between, and he might actually urinate in the toilet, and he might then only remember that you know, he has had a can to urinate. So there is a chance that the patient might not collect the whole urinary sample in the can. So which is why this is not a very favored method, your 24-hour urinary sample collection. If done, it is well and good, but it is not much favored method. So because of which you can go for a spot sample estimation. You can go for a spot sample estimation. So what do I mean by a spot sample estimation is that in a single urinary sample itself, you can go for something that is known as the albumin creatinine ratio, okay, albumin creatinine ratio, or it's called the ACR, albumin creatinine ratio. And if the albumin creatinine ratio that you obtain in a spot sample, okay, single sample, it's almost equivalent. The utility of this test is that this is almost equivalent to collecting your 24-hour urinary sample. So when the when it is more than 2200 milligram per gram of urinary creatinine, okay, so that is 2200 milligram of albumin per gram of urinary creatinine. So that is when you say this patient has got a nephrotic range proteinuria, okay. So either you can go for a 24-hour urinary sample and say that you have got more than 3500 milligram or maybe of protein and 2200 milligram of albumin, or you can go for a spot sample. Either you can go for the protein creatinine ratio or the albumin creatinine ratio. So when you take into account the urinary albumin creatinine ratio by a spot urine sample, more than 2200 milligram albumin per gram of urinary creatinine, you say it is a nephrotic range proteinuria. Nephrotic range proteinuria. Okay, so you have got to keep in mind that point. Now, you understood so far that nephrotic range proteinuria means so much of protein is being lost. So I just want you to understand one another point on the mechanism of proteinuria in general for the glomerular disorders. See, On the left hand side, you have the normal epithelium. This is your urinary space. This is your capillary lumen. Proteins like albumin. This is your endothelium. Okay, this is your endothelial layer. And this is your glomerular basement membrane. And this one is the epithelium, that is the podocyte food processes. Okay. So when you have an intact filtration barrier, all these proteins, okay, the albumin and as well as the other proteins will be in the intravascular compartment. Okay, everything fine, perfect, no problem. But what happens is that the proteinuria mostly occurs when there is a damage. Now, please listen to this carefully. I told you the filtration membrane is very important to keep the proteins in the intravascular space. But out of the components of the glomerular filtration barrier, it is the food processes of the podocytes or your visceral epithelium, okay, your visceral epithelium and the slit diaphragm that is bridging the food processes of the podocytes, which are most important for not allowing the proteins to pass across the filtration barrier. Okay, which is why in glomerular disorders where the visceral epithelium is affected, where there is a damage to the visceral epithelium, they are the group of disorders which are likely to have a nephrotic range proteinuria. So in disorders where you have the capillary endothelium affection also you can have proteinuria, but when the visceral epithelium podocyte food processes are damaged, okay, either the damage can be in various senses. Either you can have a decrease in the podocyte number, or sometimes you may have a effacement of the food processes of the podocytes. Effacement of food processes of podocytes. So what do I mean by effacement of food processes of podocytes means? Normally you see the podocytes, you have they are like the projections, okay, tight interdigitating projections you can see, but sometimes they may be simplified, okay. So in inverted comma, simplified, which means there can be a flattening of the podocytes as you can see here, okay, when there is a epithelial defect, okay, as is shown. So on the right hand side you can see an abnormality. So there is a flattening of the glomerular, flattening of the visceral epithelium, or you can say there is an effacement, it becomes flattened out. So the efficacy of filtration that is provided by the flattened, effaced visceral epithelium is not that much. So there is a chance that, as you can see in the picture, the proteins can actually leak through. Okay, when it is flattened and simplified, the proteins can leak through and there can be proteinuria. So the point I want to tell you is that whenever we are going to discuss regarding a glomerular disorder with a nephrotic range proteinuria, it is most likely that the visceral epithelium is also affected in some way. Because in case of minimal change disease, you can have a effacement of the podocytes, whereas in case of other disorders like your FSGS, you may have reduction in the number of the podocytes, okay. So we will see the individual disorders later, but the concept of a nephrotic range proteinuria and why it occurs, I think is very, very clear to you now, okay. Alright. So you have, first point I told you, you have a nephrotic range proteinuria as one of the components. So the patient, might tell you a feature like when he urinates, because of the large amounts of protein in the urine, you might have frothing of the urine. Okay, so that is one complaint that patients often say. When I urinate in the toilet, I see that there is frothing. So that is probably because of the increased protein concentration. And also know one thing, that in general glomerular disorders, they have a non-selective proteinuria. In general, glomerular disorders will have a non-selective proteinuria, which means you have different types of proteins, correct, in your plasma. So all these proteins will be actually lost. Okay, the smaller sized the larger size, all will be lost. Except certain disorders that you will learn, like say a MCD or a minimal change disease, which we will learn soon. So in that particular disorder, it is a selective proteinuria. MCD will be having a selective proteinuria where you are selectively your protein like an albumin will be lost in the urine. So there is a selectivity for the proteinuria in case of minimal change disease. Okay. So I hope proteinuria is clear. So after proteinuria, second, you know that because of the proteinuria, the patient also will be having hypoalbuminemia. Okay, hypoalbuminemia. So there will be loss of albumin also. So because of that, the blood levels of albumin also will come down. So that is a second feature, important. So third feature is that you may have edema. And why is there a edema in case of a nephrotic syndrome? See, it is quite obvious that when you have reduction in the plasma proteins, especially like your albumin levels are coming down, tell me what will happen to the oncotic pressure. There will be a decrease in the oncotic pressure. So there is a decrease in the oncotic pressure, because of which the hydrostatic pressure, oncotic pressure difference will be too much. Okay, there will be an increase in the difference between hydrostatic pressure and oncotic pressure. So because of which the fluid will actually go to the extravascular compartment. So it is an extravascular edema that occurs in case of your nephrotic syndrome. Okay. So because of this fluid going to the extravascular space, you can have a edema which may begin off in the as puffiness around the eyes. But remember, in nephrotic syndrome, since you have a massive proteinuria, and because of which you will have a extravascular edema, it will be a generalized edema, also known as anasarca. Okay, a generalized edema you will be able to see in case of nephrotic syndrome. Okay, anasarca or a generalized edema. Very clear on that. Okay, so that is one feature that you will see with nephrotic syndrome. And just one point to add, see this anasarca or generalized edema, this is more pronounced in case of children. Okay, more pronounced in children. Okay, so children are the one who are more likely to have all the generalized edema and anasarca. But when it comes to nephrotic syndrome presenting in adults, the edema may not be that much manifested. In fact, what you might have is because of the protein loss. See, it is quite obvious that nephrotic syndrome is actually a catabolic state because you are not having enough of proteins. So it is a catabolic state, so you are likely to have wasting. Okay, so the actual muscle mass may be decreased. So why the children appears very fluffy is because of the fluid, the extravascular edema. So the point I want to tell you is that the anasarca is more prominent in children compared to that of adults. Okay, so I hope edema is also very clear to you. Okay, all right. So, and though the prominent mechanism for edema in case of nephrotic syndrome is again a hypoalbuminemia, a decrease in the oncotic pressure, the sodium retention is also said to be one of the mechanisms contributing to the edema in case of nephrotic syndrome. Okay, but the major mechanism is going to be a hypoalbuminemia, decreased oncotic pressure, subsequent extravascular edema. Okay, so we have learned regarding proteinuria, hypoalbuminemia, edema. Next is hyperlipidemia. Okay, next is hyperlipidemia or hypercholesterolemia in case of nephrotic syndrome. So why does a cholesterol imbalance happen in case of nephrotic syndrome? I'll just try to show you a simple flow chart. Okay, and this is just a simple flow chart on the lipid abnormalities in case of nephrotic syndrome. Okay, simple flow chart from Feehally textbook of nephrology. Okay, so it's a simple flow chart. And what is this? This is actually from Brenner nephrology. Okay, so what is this simple flow chart trying to tell you? So this flowchart first of all tells you that there is a alteration in the LDL and cholesterol metabolism in case of patients with nephrotic syndrome. There is alteration in the VLDL metabolism. There is alteration in the HDL metabolism, as well as there is alteration in the lipoprotein synthesis. There is an increased lipoprotein synthesis. So what happens is that because of the alteration in the LDL metabolism, you will have an increased LDL generation, a decreased LDL clearance, and also remember one very important point. When you have an increased LDL generation, there is also a good chance that you will have good amount of oxidized LDL. And you know that this oxidized LDL is definitely somebody who is a villain. Okay. So you know that they are likely to produce adverse cardiovascular outcomes. So increased LDL production, decreased clearance, and increased cholesterol synthesis. Okay, there is a increased cholesterol synthesis. Okay, all this is very important. And subsequently VLDL also, the clearance is less. There is a hepatic production of the fatty acids and triglycerides. Please remember, it is very important to understand that there is hypertriglyceridemia in case of nephrotic syndrome, high values of triglycerides, increased lipoprotein synthesis, and there will be a decreased LCAT activity and increased CETP activity. I am sure you would have learned this in biochemistry. LCAT is lecithin cholesterol acyl transferase, lecithin cholesterol acyl transferase, and CETP is cholesterol ester transport protein. Okay, so because of which, all these would culminate in what? Hyperlipidemia. All these culminates in hyperlipidemia in case of nephrotic syndrome. Okay, and always remember, individuals with nephrotic syndrome are at higher risk of developing adverse cardiovascular outcomes. Very clear? Okay, so that is also clear to you. So sometimes you might have, because of the hyperlipidemia, this is the urinary sediment of a patient who is having a fatty cast. Okay, so you might have in patients with nephrotic syndrome oval fat bodies in urine, and when these fatty casts are examined under polarizing microscopy, when they are examined under polarizing microscopy, okay, they show a particular appearance that is known as a Maltese cross appearance. I am sure that at least some of you would be thinking, where else have I heard this Maltese cross appearance? Tell me, where else have you heard it? A similar appearance, even in babesiosis also you can have a Maltese cross appearance. Okay, so that's it about the cholesterol abnormalities. You will get hypercholesterolemia as well as lipiduria also. In the urine also you would have cholesterols, that is fat bodies. So you have a lipiduria also. Okay, lipiduria. So these are the components of nephrotic syndrome. Okay, very, very important. I hope you understood the basics of nephrotic syndrome and its components. And please also understand one more point, that patients with nephrotic syndrome are at higher risk of developing coagulation abnormalities. Patients with nephrotic syndrome are at higher risk of developing coagulation abnormalities. See, why does coagulation abnormalities occur in case of nephrotic syndrome? Again, you have a whole list of causes. Again, I'll just show you another flowchart from Brenner Nephrology. So it's again a simplified flowchart on why the hypercoagulability is happening. Okay, so the end result is going to be a hypercoagulability in case of nephrotic syndrome. So various components are there. One is, see, you are having proteinuria. So because of the proteinuria, there will be other substances also being lost through the urine, and maybe you will have substances like antithrombin 3, antithrombin 3. You will have a protein C loss, protein S loss, protein C, protein S. So all these are actually lost through the urine. Okay. And then because of the hypercholesterolemia, okay, because of the hypercholesterolemia and nephrotic syndrome, that per se might contribute to increased aggregation of the platelets. Okay, there is an increased aggregation of platelets that again can lead on to again coagulation abnormalities also. And because of the hypoalbuminemia, there is a increased synthesis of certain factors like factor 5, 8 and fibrinogen. So remember, the values of fibrinogen is actually increased in case of your nephrotic syndrome. And then there is an intravascular volume depletion, and it is quite obvious that whenever you have fluid leaking out of your vascular compartment and when there is a hemo concentration, that again can predispose to hypercoagulability. Okay, that again can predispose to hypercoagulability. Okay, and you might have other factors because see, patients with nephrotic syndrome may be on steroids, and that again can predispose to hypercoagulability. And also patients with nephrotic syndrome may be on diuretics. So that again can sometimes cause further hemoconcentration because of the diuretic action, and that again can cause hypercoagulability, circulating immune complexes, all factors may be there. Okay, so all these factors actually contribute, okay, whether it be a proteinuria, hypercholesterolemia, hypoalbuminemia, because of which certain other factors might be produced more by the liver like a fibrinogen, then intravascular volume depletion, diuretics, steroid therapy, the immune complexes, all will play a role in finally causing a hypercoagulable state in nephrotic syndrome. So you may have a nephrotic syndrome patient developing a deep vein thrombosis, a cerebral vein thrombosis, even a renal vein thrombosis. Okay, a renal vein thrombosis. So you might be given a clinical scenario of a patient with a nephrotic syndrome with probably an abdominal pain, hematuria. Okay, it might be a renal vein thrombosis as well. So all this is actually very, very important. So again, we have seen regarding the components of nephrotic syndrome, just a few pictures, which is what you know. This is a patient with a nephrotic syndrome. You can see the puffiness around the eyes. Yes, to begin with, there is the face is appearing like a moon faces. Okay, and you can see in this picture the edema in the lower limbs. Even a blister has formed because of the fluid accumulation. Okay. And one another point, can somebody tell me what is this? What is this nail finding in this patient with a nephrotic syndrome? So this is, are you able to see a white line here? Yes, a white line. Okay, are you able to see that? So that white line which occurs because of the hypoalbuminemia is what is called Muir-Case nails. Okay, Muir-Case nails. That is a white line that occurs because of a hypoalbuminemia in patients with nephrotic syndrome, Muir-Case nails. Very clear. So I told you patients with nephrotic syndrome are having a higher risk of developing hypercholesterolemia. So you can see the xanthelasma. Okay, xanthelasma in patients with nephrotic syndrome. It is quite obvious. Okay, very clear. Okay, so see, this is what you mean by nephrotic syndrome. But let me remind you one thing. Remember, this is a syndrome. I am repeating this again. We will see certain disorders in which nephrotic syndrome is a part, and in that you might have primary glomerular disorders. Okay, certain primary glomerular disorders in whom you will have say nephrotic syndrome as a part. You will also have secondary syndrome, that is a systemic disease in which maybe you are having a nephrotic syndrome. So let's just try to see etiology wise this classification. So this primary causes means they are the primary glomerular causes. Okay, primary glomerular causes of nephrotic syndrome. Remember, after we have discussed regarding all the clinical presentations, we will come to the glomerular disorders. Okay, So let us see what are the glomerular disorders that are likely to present with a nephrotic syndrome. Remember, out of these list, the first three are most important. First one is your minimal change disease, MCD, very important. Second one is focal segmental glomerulosclerosis, FSGS. And third one is a membranous nephropathy. These three are the disorders that can again predominantly present with the nephrotic syndrome. Yes, sometimes you may have membranoproliferative glomerulonephritis, IgA nephropathy, and certain hereditary conditions as well that can present with a nephrotic syndrome. But most important is the first three conditions. What about the details of the conditions? We will see later, okay, about the individual disorders. So then you have secondary disorders producing a nephrotic syndrome like a diabetes, very important, which can present with a nephrotic range proteinuria. And you have infections like HIV, hepatitis, that is your pregnancy induced hypertension, the preeclampsia, certain drugs and toxins and certain intrauterine infections. They are all secondary causes, okay, not primary causes, secondary causes, okay, alright. So you have understood that the nephrotic syndrome can either be because of a primary glomerular cause or it can be secondary as well, okay. Are we very clear on nephrotic syndrome? So if we are very clear with nephrotic syndrome, in that case we will move ahead with what? The next presentation, that is a nephritic presentation. Next presentation is a nephritic presentation. See, nephritic presentation is slightly different from a nephrotic presentation. So when you say nephritis, so which means it is itis, there is an inflammation that is happening here. So there is some inflammation that is involving your glomerular capillaries. Because remember, when we talked about nephrotic syndrome, we did not say anything about hematuria, because the glomerular capillaries were not involved in case of your nephrotic syndrome. So the integrity of the capillaries were intact. So no hematuria in nephrotic syndrome. But when it comes to nephritic presentation, you can have a capillary also being involved, because of which one of the feature of this nephritis will be a hematuria. One of the features may be a hematuria, which sometimes can be a microscopic hematuria, sometimes a macroscopic hematuria. Somebody might have a cola colored urine, okay. So it again depends, it's again varied, okay, cola colored urine, you can have varied presentations. So one is a hematuria presentation, okay. Now second is you can have oliguria associated with glomerulonephritis. Now oliguria is because, see, there is a decrease in your glomerular filtration rate, your GFR will be reduced in case of patients with nephritic picture. So what will happen is that the urine output will be reduced, okay. The urine output will be reduced because of the GFR. Remember, in nephrotic syndrome, we were talking, in the features, we were not talking of any decrease in the GFR, because see, per se, you do not have a, say, a glomerular injury in case of a nephrotic syndrome. Okay, it is mainly the food processes of the podocytes that are being predominantly affected. Okay, so here you will have a oliguria also. Okay, and see, there is a decrease in the urine output, the degree of which can vary. Some individuals you might have a oliguria, sometimes anuria, degree of which can actually vary. Then you can have proteinuria as well. You can have proteinuria as well. See, but when you have proteinuria associated with a nephritic picture, the proteinuria may not be as prominent as in case of your nephrotic syndrome. Nephrotic syndrome, you had nephrotic range proteinuria, that is above 3.5 gram protein or above 2.2 gram albumin. But here it is not that severe proteinuria, but still you can have a proteinuria because the glomerular capillary is involved. Though the food process is the most important component, the endothelium is also important for the preventing the leakage of proteins. So when you have a glomerulonephritis also, you can have proteinuria, but not to the tune of a nephrotic range proteinuria. Okay. And you may also have edema, okay, edema. But please understand that the edema again will not be as marked as in case of a nephrotic syndrome. You remember the bloated out appearance of a patient with a nephrotic syndrome. You are probably not going to have it with a nephritic picture. You can have some degree of edema because there is the proteinuria is again not as severe as in nephrotic syndrome. So the decrease in oncotic pressure is again not that great. So you will have edema but not to the tune of a nephrotic syndrome. But please understand one very, very important point, that in case of your nephritic picture, you will have an intravascular volume overload. Intravascular volume overload. Okay. Remember, in case of your nephrotic syndrome, it is in the extravascular space all the fluid was going. But here, because there is a glomerular inflammation, there is a decreased GFR, fluid is accumulating inside the vascular component. So there will be a fluid overload. And this can lead on to various other consequences. See, you can have a pulmonary edema, patients with a nephritic picture developing an acute pulmonary edema. And because of the associated sodium retention also, you can have hypertension. And if not adequately treated or if not identified and treated, remember this is not a simple entity. Okay, see, among the glomerulonephritis, see what is the prototype disease of nephritic picture? It is a post-streptococcal glomerulonephritis. Please remember, this is not a disorder that you can take it very lightly, because you might have a patient who is having a hypertension and he might go for complications like a hypertensive encephalopathy. Okay, and because of the accelerated hypertension, he can even have a pulmonary edema. So this is not at all to be taken lightly. Okay, you have got to keep in mind there can be a pulmonary edema, hypertension, hypertensive encephalopathy. So these are the clinical presentations of a nephritic picture syndrome. Okay, nephritic picture. And when I say nephritic, I already told you, we will discuss the individual disorders, but again, the prototype disorder of your nephritic picture is post-streptococcal glomerulonephritis, which is your PSGN. You can have picture as in case of lupus nephritis, IgA nephropathy, but the most prototype disorder is PSGN. Okay. All right. Now, having seen nephrotic and nephritic pictures, let's try to have a comparison between a nephrotic syndrome and nephritic syndrome. Remember, we are not talking of diseases per se, we are talking of the syndromes, the clinical presentations. Remember that the nephritic picture is likely to have an abrupt onset, okay, like a post-streptococcal glomerulonephritis. Okay, it is likely to have an abrupt onset, whereas nephrotic syndrome means it is mostly a insidious onset illness. Okay, and the other point is that the edema and the proteinuria, very, very important. You know that in case of your nephrotic syndrome, the edema, there is significant nephrotic range proteinuria and significant edema, whereas in case of your nephritic picture, it can be there but not as severe as in case of your nephrotic syndrome. And very, very important, blood pressure, very important. Blood pressure is raised in case of your nephritic picture, whereas in case of your nephrotic syndrome, usually, there is a volume depletion from the intravascular compartment, it goes to the extravascular space. So the blood pressure is actually normal in such scenarios. And because of the intravascular fluid overload that you get in case of nephritic picture, you will have a raised JVP. Whereas because of the intravascular depletion, why depletion in case of nephrotic is because it goes to the extravascular compartment. So it is JVP is normal or low in case of nephrotic syndrome. Okay. And hematuria is usually a nephritic presentation. Nephrotic, it is usually not there except in certain disorders. Okay. In general, hematuria favors nephritic presentations. RBC cast also is present in nephritic presentations. And the serum albumin, see in nephritic, the degree of albuminuria is not that great. So because of which, your body can compensate. So you will have that low albumin will be there in a nephrotic syndrome, whereas in case of nephritic, you will have it normal or slightly reduced because of the body's compensatory mechanisms. Okay. So I hope you are now able to understand the differences between a nephrotic and a nephritic presentation. Okay. Now this is again very, very important. So we have seen so far regarding asymptomatic presentation, macroscopic hematuria, nephrotic syndrome, nephritic syndrome. Fifth one is a rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis. So when you talk of RPGN or rapidly progressive glomerulonephritis, see, it is again a nephritic presentation. Only thing is that it can rapidly progress to a renal failure within days to weeks. Okay, so the progression will be more rapid. Okay, days to weeks. This is a rapidly progressive glomerulonephritis. So that is what you have got to keep in mind regarding RPGN. And there are lots of disorders that can present with a rapidly progressive glomerulonephritis, like a Goodpasture syndrome. Okay, a Goodpasture syndrome, and also the various vasculitis. Okay, the various vasculitis. We will see the disorders later. Okay, the individual disorders presenting with a rapidly progressive glomerulonephritis. But for the time being, understand the Goodpastures, vasculitis like a Wegener's, microscopic pan, immune complex disorders like SLE, sometimes PSD, and also post-streptococcal. See, that is what you might have a PSTN with a nephritic picture, but certain times, rarely it can progress rapidly also, where it will be a rapidly progressive glomerulonephritis, IgA nephropathy. So we will see the individual disorders later, but that is about the rapidly progressive glomerulonephritis. And what is the final one? It is a chronic glomerulonephritis. Chronic glomerulonephritis. So about chronic glomerulonephritis means it is the CKD, that is a chronic kidney disease counterpart of your glomerulonephritis. So in chronic glomerulonephritis, you will have a small contracted kidney. Okay, small contracted kidney. Just imagine a case of, say, an IgA nephropathy going on to develop a chronic glomerulonephritis, a small contracted kidney, and your corticomedullary differentiation will be lost. Corticomedullary differentiation will be lost in case of chronic glomerulonephritis. So these are the 6 clinical presentations of your glomerular disorders. So just to sum up, okay, so the clinical presentations of glomerular disease, it may be asymptomatic. You can have asymptomatic presentations, macroscopic hematuria, nephrotic syndrome, nephritic syndrome, rapidly progressive glomerulonephritis, and chronic glomerulonephritis. So these are the clinical presentations of the various glomerular disorders that you are going to see. So when we discuss regarding individual disorders, you will see that some disorders have predominantly a nephrotic picture, some disorders have nephritic picture, some disorders can have overlap. See, remember, these are not watertight compartments. There may be a certain disorder in which you can have a predominant nephrotic presentation, but with some features of nephritis as well. Okay, so remember that these are not watertight compartments. Now I'll just show you again a picture. This is an overview of the spectrum of glomerular disorders. So what is this? This is the spectrum of the various glomerular disorders. Spectrum of the various glomerular disorders, where you can see on one side is a nephrotic presentation with a significant proteinuria. On the other side is a significant nephritic presentation. So up next, when we learn regarding the individual disorders, we will learn certain disorders that are likely to present with a nephrotic syndrome, like your minimal change disease, like your FSGS, like your membranous nephropathies, which are predominantly going to have a nephrotic syndrome presentation. And there will be certain disorders like your post-streptococcal glomerulonephritis, vasculitis, anti-GBM disease, which are having a nephritic presentation. And also you can have certain disorders like say SLE, which has a whole spectrum. Either it can present as nephrotic or it can go to the other end with a nephritic. It can have mix and match combination, anything and everything is possible in SLE. You can see IgA nephropathy also predominantly towards the nephritic side, okay, and the MCGN, that is MCGN is the mesangiocapillary glomerulonephritis, which is also known as MPGN, okay, this is another name for MPGN, which is your membranoproliferative glomerulonephritis, membranoproliferative glomerulonephritis. So it is somewhere in the middle. It can have a nephritic as well as nephrotic presentation. Okay. So this is how, you know, the various glomerular disorders can present. Okay, various glomerular disorders that can present. So, you know, you have got to keep this in mind regarding the presentations. Okay. See, I'll tell you, in clinical medicine, what I have felt and from what I have learned from my teachers is that when you are approaching a particular case, remember it is not like you are spot diagnosing a case. See, there are certain disorders which you can spot diagnose. Okay, it is easy. You know, you have a patient with a myotonic dystrophy coming into your consultation room, you can easily make a diagnosis of a probable myotonic dystrophy. So certain disorders you can make a spot diagnosis. But when it comes to majority of the clinical medicine, it is always important to identify the various patterns. Okay. See, when I was doing DM, my HOD, like Dr. Thomasib sir always used to say one thing. Okay. And I think throughout my DM training, I think that is one advice that I treasure a lot. That is, see, when you approach a particular case, rather than trying to find out, okay, what is the diagnosis, rather than coming to a single diagnosis, you always ask yourself, what is the clinical presentation, what is the overall syndrome that the patient is having. Okay, when I say syndrome, it doesn't mean that, it is some named syndrome. For example, in the context of this discussion, if the patient has presented with a nephrotic syndrome, then I would be thinking more of disorders which will present with a nephrotic syndrome rather than thinking of all the glomerular disorders. You get my point? So my first aim in case of glomerular disorder, when I try to evaluate it, will be first I will try to find out, is this predominantly a nephrotic presentation or a nephritic presentation? Because once I find this is nephrotic, I have limited differentials. I can more easily come to a diagnosis. Okay. But when you don't do that, when you try to jump into conclusions, okay, this is what my HOD actually told me, always when you deal with a scenario, always try to define the syndrome. You try to understand, okay, this is what we are dealing with. Then, you go about it. Okay. So I felt that most of the stalwarts in medicine, okay, they are all having this particular approach. Okay, I recently, attended a talk by Dr. Kailash Bhatia sir, who is actually for the movement disorders. He's a world-renowned. I think he is #1 in case of the movement disorder specialty in neurology. So I was listening to his talk. He also started his talk with this particular sentence, that whenever you deal with a particular case, rather than jumping onto a diagnosis. Okay, you may be right. I'm not saying that, if you straight away diagnose, you're going to be wrong. But the probability that you are likely to make a careless mistake is more. So I always would suggest that you be systematic, so that if at some point of time you feel that, okay, I am not dealing with the correct diagnosis, you can again think of an alternative possibility. Otherwise, you might be feeling that, okay, only I am right, okay, this is the diagnosis. So it will be difficult for you to make a comeback. So always go in a systematic order, you are likely to make a right diagnosis. So, telling, just quoting Kailash Bhatia sir's words, you are more likely to be right. You are more likely to be right when you actually approach disorders in such a systematic way. Okay, that is very, very important. So that is why, I have purposefully included this module on the clinical presentations of glomerular disorders, so that you get a clear idea on how the various disorders present, so that when we discuss the individual entities, things will be a lot clear to you. Because if I straight away went ahead with discussing just the disorders alone, so you will get the points of the individual disorders, but when it actually comes to clinical practice, things would actually seem messy. Okay, so always identify the pattern and then go systematically. You are more likely to be correct. All right. Okay, so I hope you are very clear with this module. All right.